talk on cerebral palsy module in our fellows academic round. We have none other than Dr. Praveen Bhardwai from Ganga Hospital, Coimbatore. And sir will be speaking on management of upper limb issues in cerebral palsy. This is my favorite topic and sir is my favorite speaker on this topic. And after this talk, we have a case presentation by Dr. Joans, who is a current fellow in OrthoKids clinic in Ahmedabad. So first, let me introduce Dr. Praveen Bhardwai. Sir is a consultant in hand, wrist and reconstructive microsurgery unit at Ganga Hospital, Coimbatore. And sir has a lot of rewards and awards in his credits. Sir has won the first prize in national level orthopedic quiz in Indian Orthopaedic Association organized by IOA 2002. Then he had got a first prize again in state level orthopedic quiz organized by Karnataka Orthopaedic Association in 2003. Sir has done multiple fellowships like the Junior Traveling Fellowship awarded by Asia Pacific Federation of Societies for Surgery of Hand, and this Ethicon Traveling Fellowship by Indian Society for Surgery of Hand. He has also got many best paper prizes in various conferences. He has presented and been a guest speaker in various national and international conferences and has presented his work in more than 150 conferences and has more than 100 publications to his kitty. And sir has been associated with Ganga Hospital for more than 10 years now. And he's a dedicated upper limb surgeon there. So without wasting much time, I would invite sir to please speak on this topic of management of upper limb issues in cerebral palsy.
Okay, thank you, Gaurav. It is always a pleasure to be in this meeting. And today's topic would be management of upper limb in cerebral palsy. Is my screen visible? Can you just see?
Sir, you have not started we are not able to see the presentation yet.
Is it seen now? No?
No, sir, not yet.
Not yet. Okay. Now?
Yeah, now it is rolling. Yeah, now we can see the screen. You can make it full screen and you are audible also.
Okay, thank you everyone. So today we'll be talking about the management of upper limb in cerebral palsy. And actually in our hospital, the lower limb is done by Dr. Venkat Das, who is quite very well known to you all. And upper limb is done by the hand team. So it makes a nice combination. So though many times as surgeon, we feels like if we are doing everything, we feel more in control. But it's always good to have an extra brain to put input into the management of these complex things. So when we have a patient who has all the four limb involvement, usually we don't see the lower limb at all, and he will not see the upper limb, and we all see together and then we plan out. So it actually comes out quite nice. So when we see a patient with cerebral palsy, so I tell this upper limb and versus lower limb all the time in orthopedic meetings, because during our orthopedic training, I saw that we are very much comfortable and very much knowing about the lower limb management in cerebral palsy. But upper limb, somehow we are not taught much. Maybe because it is less common, or maybe it is more complicated, or maybe the outcome is not very great. So when it comes to upper limb treatment, in cerebral palsy, there are various things where it differs from the lower limb. The first of all, the surgical principles. So here in lower limb, the main aim is that the person should be able to stand. And then the next thing is walk. So then what happens is the aim is quite moderate. So if many times you'll be able to achieve the aim. But in upper limb, just the correction of the deformity is not sufficient. patient should be able to go and use the hand. Now, using the hand requires so much coordination from the brain, from the upper part of the upper limb, the hand, that overall combination has to come perfect, and then only the patient will be able to use the hand. So that is the main challenge when we are treating upper limb in cerebral palsy. The demands on the upper limb are much more because it requires to do more finer activities, and that makes the surgeries more challenging for the surgeons. And many times the outcomes are not as you expect. So you would think that the hand is looking very nice, but still the patient may not be using the hand. Though parents are quite satisfied with the outcome, but they always think it has fallen short of what they expected. So these are the main challenges when you are treating upper limb as contrast to the lower limb management. Now, as I was telling, the hand functions are more complex and they require more coordination and symmetry between the different muscles. Other challenging thing is many of the activities of our daily living can be done with one hand. So brain very quickly learns to not use the involved hand, what is called as a learned it's called as learned disuse. So we see in this video, this child we observed that even a 1 year child is totally neglecting the right upper limb. Even when the pen is given onto the right side, she takes the left hand only. So the learned disuse sets so quickly in the brain that when we are operating these children at 6 years, 8 years, 10 years, we can hardly expect any much spontaneous use of the upper limb after the surgery. At best, it would become a supporting limb to the upper limb, but they do not develop spontaneous use of the upper limb because brain has totally forgotten the hand. And that is the reason why these patients will require very extended physiotherapy, lot of dedication from the parents and from the surgeons as well. However, with all these negatives also, in a well-selected patient, the satisfaction with surgery is immense. So we see in this video, so we see how much difference the surgery makes to the appearance and to the function of the hand. Immediately, the person starts looking better. And this photo, what we saw in the previous video, this girl was in 12th class and was about to join the college. And she would tell to the parents that I'm not going to go to the college with my hand like this. And once the surgery is done, the appearance of the girl, the way she dresses, the way she walks, and with the confidence she goes to the college totally changes. Now, none of the scores can assess this. So that's why it does so much good to the patient, allows them to get involved in the society, allows them to use the hand much better than what they were doing. The hand is not normal. She is not using the hand as much as what we would expect, but still they are quite happy. And also a patient who is not able to stand, not able to hold even walker, even if we stabilize the wrist such that she is able to hold walker, will make so much difference to the outcome for this patient. The interesting thing about the cerebral palsy is that the operations are actually not difficult at all. Think we can count on our fingers itself how many operations we require to learn treating cerebral palsy right from the shoulder till the fingertip. Maximum 10 operations. We have to just use all these operations in different combinations. But the main challenge is to find a correct balance of what operation this patient requires. So I always tell to all our residents when we are operating any cerebral palsy patient, 80% of the outcome is determined before the surgery itself. So surgery only makes about 20% impact onto the final outcome what we have. So hence, in all the talks about management, I think more stress should always be on decision making. And let us talk about what are the factors we consider when we decide surgery for these patients. The first thing in our setup is to find whether the diagnosis is right, because any patient who walks a little bit like that would be termed as a cerebral palsy. Innumerable number of times we would have seen patients with birth palsy put as diagnosis of cerebral palsy, or some lesion in brachial plexus, cerebral palsy. So cerebral palsy by definition is during the birth, and it is non-progressive. So if there is any progressive lesion, we should very quickly consider a neuroconsultation, because there may be some mass occupying lesion which require immediate addressing. And we need to rule out brachial plexus, congenital contractures in these patients, because these are very different from cerebral palsy, because cerebral palsy, I think, is more difficult than birth palsy or contractures, because the brain is not involved. If the brain is involved, the overall picture changes and it becomes more complex for treatment and more complex for the parents as well. Then the next thing is, will the surgery make the hand better? So that is the main question we need to answer to ourselves and also to the patient. What improvement can we expect? Whether to do an upper limb first or lower limb first, which hand first, and how much to do at one time. Now, we have been very much taught in hand surgery, especially, that all the operations should aim at improving the function. We still believe strongly in that. However, whenever we have done assessment of outcome in our patients, we found that the parents were actually more happy with improvement in the appearance of the upper limb. Many of them told that the function is like maybe a little bit improved, but the child looks much better now. And even from the parent side, you see, they don't very commonly tell that they want improvement in appearance, because just parents also feel that they are not asking for any cosmetic improvement. They are quite happy with the child how it is. But at one level, internally, I think all of them feel that the child should look better. And that is the reason why they are satisfied also with improvement in the appearance. So we should never underestimate the improvement in appearance as one of the goal of the treatment. In fact, a totally non-functional hand can also be made to look better by fusing the wrist, and patients are quite happy with that. So equal importance to improvement in appearance, improvement in function is always the first thing. And also sometimes we could operate for improvement in hygiene. Like suppose some patient is keeping the fingers very tight, it is sweating over there. So just release of the flexors, which can allow the hand cleaning, would be quite nice thing to do. In the books, always there is a lot of mention about motivation and family support. But I think in India, there is no problem with motivation and family support. Parents are ready to do anything for the child. Patient factors are important. Intelligence level, yes, intelligent patient is likely to get better result. But it does not mean that if patient is not intelligent, we need not operate. I think if a patient is not very kind of violent, fighting in the OPD, he is good enough to do an operation. Now, type of the neurological involvement is another important thing. So some patients may have, especially the athetotic type of involvement. So in athetotic type, the main problem is, so here you see patient has got alternating type of spasticity. Sometimes it looks like an extensor spasticity. Sometimes it looks like a flexor spasticity. So these are the patients who are not a very good candidate for doing a muscle release operations. So you see, if we try to do a swan neck correction in this patient, he may develop a boutonniere deformity. If we correct the wrist flexion, he may develop an extension deformity. So this athetotic type of involvement is a contraindication for doing soft tissue procedures. However, bony procedures can still be done. So when we are examining a patient, this is one thing which we are trying to find out, that patient should not be having an athetotic type of component. Next, the age. Ideal age is around 6 years. So why 6? Because at this time, the motor patterns are usually established. So we know what is the final deficit or deformity this patient is going to have. More importantly, at around 6, children are usually more receptive to all the physiotherapy, what we are advising to them. And they have not yet developed all the contractures which may develop as they grow up. This does not mean that we cannot do operation in a person who is old. Actually, many of the textbooks say that old patient, the result is not nice, but somehow I feel we have equally good result in patients who are grown up. One thing is they look to be more dedicated to get the good outcome. They appear more committed when doing a physiotherapy. So if they don't have contractures, they would get equally good result. Only thing is we should be very careful in choosing the surgery to operate, because many of them would have developed some adjustment patterns for using the upper limb. Now, this patient was actually working as the front office person in one of the other doctor's clinic, and he came for correction of the deformity of the wrist. Now, we see this patient, he actually uses the hand for typing. See, only one finger, sometimes the thumb, but he does use. And he was very keen to get the wrist deformity corrected. Now, if we correct the wrist deformity in this patient, you would observe that his fingers totally curl up inside the palm. So that would make his function go down. And he was very keen that the typing of this finger is the main thing he likes with that hand. So that's why when we are operating in patients who have got these adjustment patterns, we need to be very careful, because if we lose this function, he will be very dissatisfied. If these things are addressed, operating in older patient, no problem at all. This patient, you see with such a deformity, and after surgery, she looks like that. She uses the hand much better. She would get married, and that way it will change her life dramatically. Now, last coming to the voluntary motor control and sensations. So that is another one factor which determines the final outcome, what we get in one patient. Now, how do we assess the voluntary control? So it is not difficult. There are no need to do very sophisticated tests. Simple thing is just put something on the table and see the patient lifting them. We basically want to see the intent. The patient is knowing that we have to go and lift, their approach to the object, how they hold it and how they lift it. That is good enough to know that the patient has got enough voluntary control. Actually, this is one thing which would determine what outcome you get in any patient what you are operating. When you are having an overall assessment of the motor function, we check about the position, how the patient is using the hand, which are the spastic muscles, which are the weak muscles, how patient is overall using the hand. And finally, we ask the patient to do some activity with the hand and see whether any new deformities are coming up. For example, many times children may be standing straight, but when we ask them to walk, immediately the elbow goes in flexion. So we want to know the functional deformities as well. We put a grading to the function what the patient has, which is quite useful to tell to the parents how much he has improved. Very important in cases of cerebral palsy, birth palsy, where parents, they really don't forget, but their expectation from the surgery may be too much. And they many times tend to say, oh, like he's not improved much. But when they see the preoperative photo, they will be really amazed how much difference has happened after the surgery. Same thing with the scores. It is useful to show to the parents and also for our academic purpose. House grading is quite simple. It is just about how the child is using the hand as an assist or spontaneous use, and the scoring goes from 0 to 8. Now, after we have done an assessment, the main question we need to answer to ourselves and to the parents is what improvement are we expecting, or what is the aim of the operation? it has to be really very realistic for ourselves also, because many times we, especially the hand surgeons who have gone from tendon transfers, even birth palsy, and then going to cerebral palsy, they think that the outcome would be as they get in tendon transfers. But tendon transfer in cerebral palsy do not give that type of outcome. So we need to be very realistic about that. And parents have to be really told about what we are going to expect out of these operations. They must understand that the basic problem is in the brain and the connection to the hand, which we are not treating. We are going to position the upper limb in a better position where it looks better and is more likely to be used by the child. And then on, the function has to be improved by repeated training and repeated reuse of the hand. Now, if we see this patient was actually a dietitian in our hospital. She was doing an internship. Then she came and showed that, okay, this problem is there. And she is quite intelligent, talks very nicely. And girls, they have a nice style of, they will hide the hand with the dupatta. And she used to always keep that dupatta wrapped on this hand. And we actually didn't know that she has got a cerebral palsy. So she was quite good. Then when she was about to join the job, that time she showed that the deformity is there. That's why she keeps it hidden in the dupatta. And she was quite nice patient to operate on because good voluntary control, intelligent, good power of the hand. And then after the surgery, she was 3 years as a dietitian in the hospital, and actually nobody knew that she has problem in the right upper limb. So this is the deformity what she had. Good flexion, but when she opens up the fingers, the wrist goes in flexion deformity. Wrist extension is poor. So this was our main thing what we required to correct. So we see the result after the surgery. The wrist is very stable. It is in good shape. She is nicely approaching to the object, lifting them, maneuvering, and putting it back. So this is the kind of outcome which we can achieve if the patient has got a good voluntary control and patient is intelligent, committed, and able to cooperate with your post-op rehab. This is what I meant when you are operating in a grown-up patient. So this patient would do a physiotherapy rehab for hours and hours because she wanted to become better. Many times small kids, they don't realize that operation is being done for their good and it is going to make great impact on their life. This patient has got such a beautiful result and she was quite happy with that. But most of the patients would fall in this category where the intelligence is moderate, they have poor motor control, but they are able to manage activities. In such patients, our main aim is that we should be able to get a stable wrist, which looks better, and patient should be able to use this hand for bimanual activities. So if the patient is able to use the hand for bimanual activities, it is considered a good success of the operation. And even the parents and patients also are quite happy with the outcome of our surgery. In very poor control cases where you don't have any much voluntary control at all, I think even if we are able to stabilize the wrist so much that they are just able to hang on to the walker, making the lower limb rehab possible also is a good aim to have. Results can be very, very satisfying. So many times we see that a PIP joint fracture person would actually be more dissatisfied than a very severe cerebral palsy patient because they would have seen a dramatic change from before operation to after the operation. So it is a very nice and satisfying field where you can be quite happy in that clinic. Now, a common question is whether to do an upper limb first or lower limb first. Think if the lower limbs are so severely involved that a patient would always require a walker to walk, we do the upper limb first so that the rehab becomes easy. And then we go to the lower limb. Which hand first? Parents would generally ask to do the more severe hand first. But ideally, it is good to do the less involved hand first, because once that is corrected, they will be more happy with your outcome and they will agree for the more severe one. How much to correct at one time? This is totally a school of thought. Some people would say that you go sequentially from the shoulder to the fingertip. Others would say do everything at one time. If you start doing sequentially, what happens is there are multiple stages of operation. Children, every year they will be coming for some surgery. It will take around 3 to 4 years for them to get better. More than the surgery, the rehab time actually takes off much toll onto the parents. So after a surgery, 1 month, 2 months of rehab, and they are continuously busy for years. However, if you do a correction of all the things at one time, it becomes much nicer. Now, this patient, you see the wrist deformity, the fingers are down, how he goes and pick up the things. So he has a deformity in the wrist, deformity in the fingers, the elbow is having a flexion deformity, shoulder was reasonably okay. So this patient, typically what anyone would do is FCU to ECRB transfer, fraction lengthening. He is good. But observe that when he is trying to lift up an object, he has to bring his thumb out and then pick up the object. So actually the patient himself is telling that correct my thumb, let the thumb come out. So when we are assessing our FCU to ECRB result, this was a very striking thing. Most of the patients would bring the thumb out and then go like that. So imagine if this patient, we had done the thumb during the first operation itself, and his function would be much better. This is the same patient after doing the thumb correction. So we did a tendon transfer to bring the thumb out, and you see immediately the function improves. So that gives us a thought that if we correct the thumb deformity when we are correcting the wrist, we save a lot of time for the patient and for the parents as well. So presently we aim to correct all the deformities right from the shoulder to the fingers and the thumb. Finger sometimes we leave for the next stage because we cannot really expect what deformity they will develop in finger after correcting the wrist deformity. But thumb generally we try to combine with the wrist. So same like lower limb, single event multiple level surgery is the in thing for cerebral palsy for upper limb as well. And this patient, if you see, that is the pre-op photograph and this is the post-op photograph. So all the things like posture of the hand, how they are using the hand, with what effect they are using the hand, and overall function of the limb actually would dramatically improve in these patients. And you get all at one stage. Again, is good for a center like ours, where patient may come from different places very far away. This patient was from Maldives. So the best thing is during one rehab itself, you are able to put the patient to function. So that is a nice thing about doing us. Now, the last thing, some patients may have very severe involvement. So according to all the textbooks, it would come as he is not a candidate for surgery. That's true. He is not a very good candidate for surgery. But then what? He has to just remain like this. So we actually go a little bit more out of the box, more aggressive in these patients, because parents also understand that he has been like this from 16 years and nothing is going to change if anything is not done. So we actually go a little more aggressive and then go out of the rules and try to stabilize the wrist by tendon transfers or by fusion. And in such a patient, even if you are able to get a stable wrist, this is when he was admitted for spine surgery. And they looked so happy as if the hand has become so nice and he is able to do a lot of activities. For a patient like this, who is able to blow up these balls, is like he going and touching the sky. So think a patient with severe involvement on both sides, we can go out of the rules. Make sure that you don't deteriorate anything, but even a mild improvement in function is much appreciated by the parents and their relatives. Okay, thank you very much. We'll take some questions and discuss all the points what come by. Thank you very much.
So, thank you, sir, for detailing all the principles about the management of upper limb issues in cerebral palsy. We have three
So
questions.
Gaurav,
Yes, yes,
can
sir.
I interrupt?
Yes, sir.
Praveen,
Yes, sir. Tell me.
do you have that talk ready, that how you make decision about surgery, so I was expecting that talk, that you, what the moment you see when to release flexors and when to consider pronator for transfer and brachioradialis. And then the one which you presented ISHS,
Okay, yeah, I have.
you
Actually,
have, can you,
yeah, we will. I will share that. Yeah, actually,
because
the talk. I think I was talking with so much involvement that I have finished only 1/3 of the talk which I thought, and the time
no,
is
I mean,
30 minutes.
this is the what you say is a philosophy of upper limb surgery you discussed,
Yeah,
and I agreed with all the points. Now I want you to briefly teach that what are the examination points when we take decision,
yeah.
So a further 10 minutes would help a lot of them. I have heard that lecture twice, but I want to hear it again.
Yes, it is ready.
So
Okay.
Gaurav,
Is
I
it?
think we should listen to this and then we should discuss it. Yeah.
Agreed, sir.
Is it seen over there now?
Yes, sir.
Yeah. Okay. Actually, this assessment and decision making. So once when we were having one cerebral palsy CME in Mangalore, and my mentor, Dr. Jagannath Kamath, he organized that, and he was telling that all the PGs will come. So you should make it simple and tell them they should not get very feared of cerebral palsy and never operate upper limb. So me and Venkatdas were going in the train, and all the time I was thinking how to make it simple. And from there on, I thought this. And after that, whenever I presented this to anyone, I have felt it is an easy way to assess and decision making in these patients with cerebral palsy. So when you start examining a patient for correction of wrist deformity, so these are the 6 steps we need to follow. And with these 6 steps, you will be able to tell whether you should operate that patient or no, what outcome you can expect, what operation you need to do. All the 3 important questions you will be able to answer. Now, first thing, ask the patient to hold your fingers. So by doing this, you are checking whether the patient has got a voluntary control on the finger flexors. So if the voluntary control on finger flexors is present, that means that patient can be operated. And function can be improved in that patient, because if voluntary control is there, surely the patient will be able to hold something if the wrist is made stable. So this will tell us that the patient can be operated and function can be improved. If patient is not able to hold your fingers at all, then that patient cannot be improved in function. You can still do a fusion, but it is not going to improve the function. The second thing you check is whether patient has got finger extension or no. In any position of wrist is not an issue. Patient should be able to open up the fingers. So if patient is not able to open up the fingers at all, the fingers remain jammed in the palm, that means that patient cannot be made to use the hand for independent activities, because for independent activities, a person has to open up the fingers. So this will tell us whether your aim should be to make the hand only stable and a passive assist, or whether you can make it an active use of the hand for spontaneous use, where person is able to open up the fingers and go and hold. So this will tell whether you should operate. This will tell whether it is the aim and goal of the operation. Now, third thing is you check whether the wrist flexors are working. So wrist flexors are the common donors to correct the wrist and the finger deformities. So you check whether the FCU, FCR both are working or not. Both should be working, because if FCR is not working and you take FCU up, patient will start having their extension deformity. So both should be working for the one to be taken. So you check for the FCU, FCR, palmaris longus. The next three things are, they will tell us about what operation you should do. So you ask the patient to do a wrist extension with fingers flexed. You see, this patient is able to extend the wrist with fingers flexed. This patient not able to extend the wrist with fingers flexed. So anyone who is not able to extend the wrist with fingers flexed means that the wrist extension power is very weak, and this patient requires augmentation of wrist extension by tendon transfer or by wrist fusion. This patient is doing an extension with fingers flexed, though he had a wrist flexion deformity, but once the fingers are flexed, he is extending the wrist. So he does not require any tendon transfer for wrist extension. Same patient, you ask to open up the fingers and then extend the wrist. You see, on opening up the fingers, same patient not able to extend the wrist. So this indicates that the wrist extensors are strong enough, but the long flexors are spastic and tight. They are not allowing the wrist extension to happen. For such a patient, the main aim or main goal for the surgery is to release the long flexors so that the spasticity is reduced, and that will itself allow the extension of the wrist. So here we need not put a strong tendon transfer to get the wrist extension, because the wrist extensors are already working, and it is the finger flexors which are not allowing them to act properly. Now, how severe is the flexion contracture is assessed by Volkmann's angle. It is important to know this because if the patient has got a 90 degrees of Volkmann angle, that means the fractional lengthening is not going to be sufficient to correct that. You require to do some amount of bone shortening by proximal row carpectomy or so, or you have to very aggressively shorten the wrist and fuse the wrist. The Volkmann angle till about 30 to 40 degrees only can be addressed by a fractional lengthening. Otherwise, more aggressive lengthening of the flexors may be required. Now, the last thing what you do is you hold the wrist stable and see whether the patient is able to extend the fingers or not. Now, this patient, you see the wrist extension was not there and fingers were going into extension. But when we stabilize the wrist, you see the finger extension is still complete. Many patients, you would see that the fingers would fall down. So if fingers are falling down, you passively extend the fingers and see. If passively it is extending, that means there is no tightness of the flexors and you need to put your tendon transfer to the finger extensor. But if the patient is actively extending the fingers to this level, that means the long flexors are totally okay. There is no need to do any release of these flexors, and we need to do only FCU to ECRB transfer in this patient. So by these 6 things, you'll be able to decide what operation to do for which patient. Basically, the most commonest operation is FCU to ECRB transfer, which is actually done whenever the wrist extension is poor. Now, just to reinforce the 6 points what I told. So this patient, see here, she is able to hold our hand. So that means voluntary control is there. She is able to open up the fingers. That means if we operate, she will be able to use the hand for independent activities. The wrist flexors are working. She is not able to extend the wrist with fingers flexed or with fingers extended. So that means she requires a tendon transfer of FCU to ECRB. On stabilizing the wrist, her fingers also were not going fully up. So she has tightness of the long flexors also. So this patient, we did an FCU to ECRB transfer, fractional lengthening of all the long flexors. We also did the thumb, and this is the outcome what you get. Another patient, wrist flexion deformity. Open up the fingers, so that means she can be trained to get independent function. No wrist extension at all. So this patient requires tendon transfer of FCU to ECRB. Since on stabilizing the wrist, full fingers are opening, there is nothing required to do for the long flexors. So the procedure will be only FCU to ECRB and she will get a result of this kind. So that is the way in which you can actually make the decision appear a little bit more simpler and easy to explain to somebody like students, PGs, and also they don't get very feared with the operation. Thank you.
Yes, Praveen, as we discuss this case and continue to that, what is the degree of wrist extension should be there when we do rinse transfer, FCU to ECRB?
The passive extension, you mean?
Oh, no, what is the end point? When we fix the FCU to ECRL, what should be the degrees of wrist extension?
Yeah. So intraoperatively, when you are doing an FCU to ECRB transfer, the wrist, after you leave it to fall with the gravity, it should go till neutral or 10 degrees flexion. It should not remain tight in extension. So what we would do is we do an FCU to ECRB, we take one stitch and we see whether how much the wrist is falling. It should go till neutral or 10 degrees flexion. If it is holding in extension, that means the tension is too tight. And these people, especially when we are operating in younger children, we need to be very careful because the spastic muscle does not grow as much as normal muscles. And then later at 5 years, 6 years, they may come with an extension contracture. So the tension has to be less. And since these patients rely more on wrist flexion to open up the fingers, if we do a too good correction for the wrist extension, their finger opening will suffer. So we rather be happy with slight flexion deformity than the wrist being too much in extension, fearing that he may develop extension contracture and also finger opening also will suffer.
Yes, that's a great insight. The second question in continuity is, sometimes we do not get the length of FCU because the neurovascular pedicle of FCU is, sometimes inferior than with what we expect. What do you do in that case? Do you extend your dorsal incision proximally, and what do you do for that case?
Yeah. So, yeah, that is a good question. And I think not many people have written about it. But this extra pedicle of the FCU, what we are getting, which we often see that when we are dissecting the FCU, it is an accessory pedicle. It is not having an important implication on the vascularity or the innervation of the FCU. That is just an accessory thing coming, and main pedicle, neurovascular pedicle, is above the elbow. So that goes inside the FCU and goes on the undersurface of FCU. Those small tweaks which come in the proximal third of the forearm are not having any implication on the function or viability of the FCU. We can divide them.
So you mobilize till proximal ulna, right?
Yeah, still the proximal third of the forearm. So we actually commonly put one nice marking. So you divide the forearm into proximal third, middle third, distal third, middle third, proximal third. So our mobilization will be till the proximal third, middle third junction. In the middle third is the place where what you told commonly that one small pedicle would be coming from the ulnar artery and the nerve and entering the muscle. But that is an accessory one. There is no fear in removing that because the main pedicle is going under the surface of the FCU and it is safe there.
And have you ever experienced the length issue for the FCU? Even after mobilizing, you are not able to do this? I mean, you do pulvertift or end-to-side repair?
We do pulvertift repair, and actually we have not experienced, after we have mobilized till the proximal third, we have not any time experienced any shortening of the tendon. It always comes nicely. But as you correctly mentioned, if we are fearing about that pedicle, then we may feel like we are falling short. We mobilize well, and we should make sure that the FCU, while going to the dorsum, it is transversing in the middle third of the forearm. If it is going more distally, then it is turning very acute and you may fall short of length. But if it is going around the middle third of the forearm on the dorsal side, you will not fall short of length. It will come correctly.
Perfect. Yeah, Gaurav, sorry
Uh,
for you can go ahead with questions now.
so another questions are how selective motor control guide the outcome.
Yeah. So selective motor control, you mean each finger like that?
So that question is, Praveen, I see some children when we ask them to do a task, they kind of flex the opposite limb also.
Okay,
So
okay,
they
okay,
face.
okay.
So we
Mm-hmm.
see that they do not have, unless they move the other extremity,
Correct,
they
correct,
don't.
correct.
And the secondly, when you do ask them to pinch, they will flex all the fingers. So they are not
Correct,
very
correct.
good.
Yeah. So I think it does have some effect on the operation outcome, but we are not having any good way to correct that. Many children, even after surgery, they will be moving the other hand to do that.
Mm.
So maybe it is not having a very detrimental effect to the outcome, and patients can be trained. So many
Mhm.
times, once the hand function becomes good, we tell them not to move this hand and try to concentrate only on this. It is very difficult for them to break that cycle, but it is not having a very dramatic effect on the outcome of the operation. I think it is okay.
Another question is how the result different between pronator teres release and pronator teres rerouting.
Okay. Yeah, that is a very interesting and thoughtful question. And actually, one easy way is to tell that both may work almost similarly. So, actually, to tell about that, you see the pronator teres release and doing a transfer. So, when you are assessing a patient, if you don't have any full passive supination, so that means our main problem is that we are having the tightness of the pronator. So if tightness of the pronator is there, it must be released. We don't know whether it is the release which is working better or whether it is the transfer which is working better. So it's a nice thing to tell that we are having one conference in Paris on spastic upper limbs. And there was one person who was presenting very good results of pronator teres rerouting. And immediately after his talk, there is another one person talking on biomechanics of tendon transfers. And he says that pronator teres rerouting biomechanically cannot work. And it becomes so embarrassing for the person who was presenting before him that what could he say? And he put a very nice thing. So he says biomechanically, suppose a tendon transfer is going through the center of rotation of that movement, that means it is mechanically inefficient. See, actually what he tells is correct. So suppose there is the rotation, this rotation is happening and tendon transfer goes through the center of the rotation. It is at such a plane that it is not able to exert any force. So
Mhm.
biomechanically, he put a lot of things and he made it look so embarrassing for anybody to tell that we do pronator teres rerouting that after that, nobody was talking about pronator teres rerouting. So I think biomechanically, it is only that release which is working.
To
And
me, Praveen, we
Yeah.
have seen two types of cerebral palsy patients. I
Yeah.
mean, or two morphology. Like one is spastic, and then you ask them to do certain degrees of supination, so they can do little less than mid-prone, right?
Mhm. Yeah.
And the other set of patients where even you can do passive supination full, they cannot
Mhm.
initiate supination at all. So I tell my residents or fellows that these are like CV stroke patients.
Mhm.
The the pronation deformity is more because of supination weakness rather than pronator teres tightness.
Correct.
So a patient who has good passive supination but cannot initiate even a little supination, there
Yeah.
is weakness,
Yeah.
and their pronator rerouting would help. But a
Correct.
patient where he can initiate certain degrees, but it's not going to functional range, there
Yeah.
you just do release.
Yes.
So
Yeah.
of course, this is my
No, true. This is
subjective assessment.
yeah, this is true. So this is how this Tonkin classification goes for the pronation deformity. So if passive rotation is full, but they are not able to do actively, then it is recommended to do pronatories rerouting. But what I was trying to say is, this is one thought which I got from one meeting, and after that,
Yeah.
actually, after that, I have never done a pronatories rerouting. So
Yeah.
somehow it got stuck in my brain that what he is telling is correct. So in situation like what you told, where the passive rotation is very good, but they are not able to initiate the supination, actually it is good to do other transfers which work most efficiently, like FCU. So FCU to brachioradialis is very super transfer for getting supination.
Mhm.
So you will get a very perfect supination, which you struggle to get with the pronatories rerouting.
Mhm.
So FCU to brachioradialis is a very nice operation, and patients see when we are seeing a patient who is not passively actively supinating, but passively they are okay. In our Indian situation, their main aim is that we want to eat with that hand. That's why they are asking supination. This pronatories rerouting somehow is not able to get that much supination that you can go and eat. But if you do this FCU to brachioradialis transfer, you would see that the patients get full supination and they are able to go and eat with that hand. So it is much stronger. So though there is a role of pronatories rerouting in those cases, if FCU is not available to use for supination. Otherwise, we will first consider doing an FCU to brachioradialis.
Is there any other transfer if you are also doing simultaneous greens transfer? Where most of the patient has
Yeah.
pronation and wrist flexion deformity.
Correct. So if you are doing a greens transfer, actually biomechanical studies show
Yeah,
that the
gives
FCU to ECRB itself is going to improve supination.
supination. Yeah.
So when you are doing a greens transfer, I think it is good not to do a supination transfer at same time, because this
Okay.
FCU to ECRB also is going to act as a supinator. And if you do too much of supinator transfer, you may lose pronation.
Supination deformity. Yeah.
Yeah. And more importantly, because these patients who are using both hands at same time, because of their hand is not very good, they use the hand for bimanual activities. If pronation is limited, then their desktop activities suffer.
Mhm.
So it is better to be little less aggressive in trying to get supination. And one of the ways of being less aggressive is to do a pronator quadratus slide rather than releasing of the pronatories.
Mhm.
So in the distal third of the forearm, the pronator quadratus would be there. So we do only the fractional lengthening and slide, subperiosteal slide of the pronator quadratus. So what it does is it reduces the pronation spasticity, but still maintains enough pronation for doing all the activities. So there is no risk of developing a supination deformity in that.
So you have a single volar incision for that or a separate
Yeah.
two volar incision?
The same volar incision where we have harvested the FCU, we go deep and then do this fractional lengthening of the pronator quadratus.
From the
And
ulnar side.
from the ulnar side. And the same thing is taken proximally to release the intraosseous membrane, which
Dr. Anil
Anil
Agrawal
was asking. No? So the same incision, actually it is not described because we have not written it yet. So intraosseous membrane release, the surgical procedure is described from the dorsal approach. The volar approach is not described, but we just hug the ulna and divide the intraosseous membrane just next to the ulna. We need to be careful not to go more central because the posterior intraosseous nerve will be going just behind the intraosseous membrane. But we are close to the ulna, then there is no risk of anything.
So I have been doing intraosseous release from the pronator teres insertion.
Yes, okay.
So that can be done, and but you remain flush to the bone, as you say.
Correct. Yes.
Yes, Gaurav. Any further question?
Another question is, it is observed that after thumb adductor release, there is hyperextended index finger, flexion of PIP joint, some interosseous lumbrical malfunction. What is the reason and how to avoid?
There is hyperextended index finger with flexion of the PIP, some interosseous lumbrical malfunction. What is the reason and how to avoid it? Yeah, I think index and thumb generally go together. No, these patients who have this lot of severe thumb deformity, the index finger also lags behind. So one of the ways to correct is, so when we can, for suppose extension lag is there, we can do a side etching of the index to the middle finger. So both will come up then. So at the same time, when you are doing thumb, we can do that. Many patients may have flexion deformity at the index finger. That is because their flexor is tight. So if we are able to assess it preoperatively itself, we can do a fractional lengthening of the index finger flexors. So that way, it is not a very characteristic picture that everyone will have this, but index finger deformity with thumb correction can be done. It will be basically two types. One is the index is not coming up. Second is MCP is coming up and IP not coming up. If IP not coming up, we need to lengthen the flexors. If MCP not coming up, we can take the extensor and side edge to the middle extensor.
So Praveen, this is, I feel it's an iatrogenic kind of, I've seen many a times when I do the thumb adductor release from the third metacarpal, post-operatively thumb is abducted, but patients would complain that index finger is not extending. So it's not about tightness of flexor that was there before, and post-operatively it happens. What I feel is whether I'm injuring this interosseous or lumbrical and inducing this deformity.
Okay.
Have you experienced that any time, or how do you release your thumb adductor?
Yeah. So we release the thumb adductor from the third metacarpal only. So this mative release over there. But actually, very specifically, we move the lumbricals and the lumbrical innervation on the medial side and then only release. We've observed this deformity very commonly, but never when we have done only the thumb. So you see this thumb, when we are correcting, we would be correcting the wrist also. So when the wrist is corrected, after wrist correction, very commonly you will see that the index has gone down. That is not because of the thumb, I think. It is more because of the wrist. So once the wrist comes, only the true deformity of the index is revealed.
Okay.
Yeah.
What I have seen in certain number of patients, although I always ask them to wait, and no one has come for correction or persistence of this deformity. So this might have been getting corrected by itself.
No, we have operated actually many patients secondarily for the index. And thing which was done was side etching. It was dropped down like this. It was not coming up. That was primarily because once the wrist is corrected, we started observing that the index is dropped down. So we have done a side etching to the middle finger for quite maybe around 4 or 5 patients. When we have done any other like elbow release or any other operation, what we have done. So it is more than happening because of the interossei. I think it is the once the wrist is corrected, this deformity gets revealed. But I will keep a note when we are seeing it next time. Yeah.
Right.
Okay, so the last question is, what is the ideal age for wrist fusion?
Yeah, this is again a very interesting question. So the ideal age, you just take an X-ray and see that the physis is fused already. We can go for fusion, which is, I think, around 16 years is good age. But now many patients we have done before 16 also, maybe 12 years, 10 years we have done. So what we do is we do not disturb the distal physis of the radius. We only remove the cartilage, and anyway enough bone is there. We put a plate and remove the plate after 1 year. So, and make sure that the screws are not in the physis. So minimum what we have done surgery is around 12 years in a cerebral palsy patient. But birth palsy patients, we have done surgeries, wrist fusion even for 5 years, 6 years and all. But in cerebral palsy, 12 years have been the earliest. So wrist fusion, you put a
Yeah.
plate, and after 1 year, remove the plate and make sure that we don't damage the physis. But if the deformities are not very severe and you are able to manage, 16 years is a good age to do the fusion.
Right. So, shall we take the case also, sir, if you have time?
It's a small case. Let's there's no result, so it's a question case kind of. Let's
Okay,
go
sure.
through it quickly, Joanne.
Yeah, sure. Okay.
Yes. Uh, Good morning, everybody. I hope my screen is visible. We had this 7-year-old boy who presented to our OPD primarily with complaints of reduced usage of left hands. He had a preterm birth at 8 months, followed by delayed cry, for which he had an ICU stay of more than 2 weeks. There's history of global delay in milestones. At the age of 3.5 years, he had injection botulinum toxin in his pronator teres, thumb adductors, and wrist flexors. And now at 7 years, this was his complaints. So we can see the wrist is in an attitude of flexion with a thumb in palm, with a poor selective control. He's unable to actively extend his wrist. This is his voluntary control. So his grasp and release is also poor. So these were the issues. The forearm, he could not initiate supination, and the wrist was in palmar flexion and ulnar deviation. And he could extend the fingers when the wrist was held in neutral. The hand had poor grip and release, poor selective control, and the thumb had a contracted first web space, and he could not abduct the thumb, but he could extend it. So the question was, what can we offer for the child for the upper limb?
Yeah. So does he have finger flexion is there? He is able to grasp our finger or some objects like that. I saw he's holding between the fingers only like this. Does he a long flexor flexion function is there?
Yeah.
No, sir.
Yeah, go ahead. So, Praveen, he is not very, I mean, when you ask him to hold it, he takes time to grab your finger. That's what I say, that he did not have very good selective control. So he needs a certain juggle of movement to hold. This is how he needs a supination to hold it. And it's difficult to assess. But he can do a good finger flexion actively.
Yeah. Yeah, it looks okay, I think this patient has got a little more severe flexion deformity, and hand function also is the long finger flexion also not very good. So our goal for him will be to correct the wrist deformities and get it in extension. Now, if his FCU and FCR both are working and they are in reasonable amount of voluntary control, we can do an FCU to ECRB transfer for him. Will not combine the thumb deformity correction and the finger correction in this patient because we don't know how good it is going to work. So first stage only FCU to ECRB transfer, and pronator quadratus and interosseous membrane release. That will improve the supination a bit, and also FCU to ECRB will get the wrist straight.
Yeah,
Thumb
even
if
I could not.
required, next stage we will consider. Yeah.
So even I could not assess his FCR power. When you passively supinate and ask him to flex the wrist, he could not do voluntarily. But then once you leave him, he will do wrist flexion. So it was difficult to assess his FCR power. So I was a bit worried that, but as you said, that will transfer FCU in a way that the wrist should be neutral or little volar flexed at the rest, so that we are not overcorrecting it.
Correct. Yes. I think this child is quite young. Another way, many times patient may not be able to initiate the FCU. Another way is we just take the wrist and try to move it in extension. And because of spasticity, suddenly we will feel some tightness of the FCR. So if that much tightness is there, it is enough. Another thing is we ask the patient to try to open up the fingers. You see, finger extensors and wrist flexors are synergistic. So when a person is making an attempt to extend the fingers, we can palpate the FCR contracting. So if that much contraction is there, that is enough to prevent the wrist extension deformity, and we can go with FCU to ECRB transfer.
And why? I was thinking that thumb adductor is very tight.
Yeah,
and,
it looks very tight.
He can do extension well and not abduction. So I was thinking of the EPL rerouting together.
Yeah, EPL rerouting.
Why you want not?
Yeah. So thumb, somehow I feel that, you see, when we are correcting the thumb, no, there are 4 components which we need to address. One is the skin contracture, the adductor and flexor spasticity, weakness of the extensor, and instability of the joint. And when all 4 are done at same time, only the result is best. So this patient, suppose we do only the EPL rerouting, it comes out, but his MCP is going in hyperextension and his metacarpal is adducting a lot. So that alone will not make much effect to his outcome. So I would rather think that first we correct the wrist and then go full throttle onto the thumb by an aggressive adductor flexor release, fusion of the MCP joint, and EPL rerouting. And even when we are routing the EPL, think after rerouting, we just take the palmaris longus and hook onto that rerouted thing. So it will passively keep it over there and it will add further power to the EPL.
And what about doing the volar capsule tightening? Because this child, when I passively did this, there is minimal hyperextension of the MCP joint.
Yeah.
So I was thinking that Z-plasty, release, EPL rerouting, and capsular imbrication.
Yeah,
and not the fusion, because it's just 7. No?
Yeah. So that's what theoretically it appears that we do a sesamoid arthrodesis or capsulodesis, but somehow it stretches out with time. And MCP joint especially, there is enough amount of bone which is already formed in 7 years old age child. So we do a kind of chondrodesis. So when you are excising only the cartilage, you will have a nice central part which has a bony component. We approximate that and fuse.
Put a wire.
Physis is not damaged because the thumb, the metacarpal has a physis in the base. So that's why the physis, there is no risk of any damage. Proximal physis is there, but there we need to be only removing the cartilage. And fusion really works well because fusion is converting it into the stable structure now. So if the MCP is unstable, half of the force is lost over there. So if it becomes stable, then the tendon also works more efficiently to bring the thumb out. Yes.
So this patient is coming from far, so I was thinking of doing everything together.
Yeah, then you do all the 4 components of the thumb then.
Yeah.
So MCP fusion and release of the adductor and EPL rerouting plus attaching the palmaris longus onto that. So palmaris longus will keep it rerouted and also will add to the power of the PPL.
Right. So I'll try to, and we'll try and take better videos. I'm operating this child on Monday,
Yeah, sure.
and we'll send and share the result.
Sure. Ji.
So it was a great talk, Praveen, and
Thank you,
don't
Malin.
know
Thank
about
you,
others,
Gaurav.
but I enjoyed it a lot.
Thank you so much. Thank you,
Gaurav,
Gaurav.
you can conclude the session.
Yeah, so thank you, sir, for explaining everything in detail, including the philosophy and the principles and the various surgical techniques, and giving us your crucial time for this much awaited webinar. And with this, we also conclude our CP module. I will make a folder of all our talks and share with our fellows soon. So we'll come again with yet another module soon. And yes, so with this, I would like to conclude this session, and I would like to thank Dr. Praveen, Maulin sir, and everyone here, and for choosing me to
So
moderate.
thanks,
Thank
Gaurav,
Thank you,
for
Gaurav.
taking this responsibility and coordinating. And from next week, we are starting day-to-day pediatric orthopedic module, and Dr. Chinmay Sangole from Amravati, he's leading that module, and he has jotted out a very nice program, about 12 lectures, and faculties from all across the India, they will contribute, including some metabolic bone disease where Shalmi and Ruchi would contribute. So that will be a very interesting session as well. I encourage fellows to present cases. And in fact, I should talk to their bosses now, because everyone should take advantage of this, and not only ortho kids fellows. Fine. So we'll meet next week with some other interesting topic. And thanks,
Sure.
Praveen, for your
Thank you,
time.
Malin. Thank you,
I
Dr.
enjoyed it
Gaurav.
thoroughly. Have a good
Thank you,
day.
Gaurav. Bye. Thank you.
you so much.
Take care. Bye-bye.